Hi, everyone. Thank you for joining us today for MVC's first Cardiac Rehab Workgroup of 2024. My name is Christy Degner, and I'm the Site Engagement Coordinator for MVC. I look forward to facilitating this workgroup today. So today's Cardiac Rehab Workgroup will feature a presentation by Devraj Sukul. Devraj Sukul is a clinical assistant professor in interventional cardiology at the University of Michigan, director of the Clinical Quality and Outcomes for the Cardiac Catheterization Lab, co-director of the Michigan Cardiac Rehab Consortium, and associate director of the Blue Cross Blue Shield of Michigan Cardiovascular Consortium. After completing his general cardiology, health services research, and interventional cardiology training at the University of Michigan in 2019, he joined the faculty at the University of Michigan and the Ann Arbor VA Medical Center. He treats complex coronary and structural heart disease using minimally invasive methods. His research focuses on understanding gaps in care quality and developing strategies to improve cardiovascular care. Thank you, Devraj, for being here today. Before you begin your presentation, I have a few housekeeping items to review. So first, the session is being recorded. The slides and the recording will be shared with all attendees following the work group. Next, we will be monitoring the chat throughout the presentation, so feel free to add questions there. We'll also have some designated time at the end of Devraj's presentation for an open Q&A and discussion. And lastly, your feedback is very important to us. If you could please complete the post-work group survey in a link that will be provided in the chat at the end of the session, as well as in an email following the work group. That would be greatly appreciated. And as a reminder, for hospitals participating in MVC's component of the Blue Cross Blue Shield of Michigan P4P program, who would like to receive attendance credit for this work group, the survey is mandatory. Please note that if you are hoping to get this credit, please indicate the one hospital that you are attending on behalf of so that we can appropriately give you credit for that work group. So without further ado, I will turn it over to Devraj to start his presentation. Thanks for being here.
Thanks so much, Christy, and thank you for the invitation from MVC and from the work group. I recognize a lot of names on the list here, which is always great. And hopefully I won't take up the whole time, but that should leave enough time to keep this informal and interactive, ideally, since I think we're all here with a similar mindset and goal. Let me share my slides. I always mess this up, even though we've been in a Zoom era for 5 years now. My slide showing up? Yeah, looks good.
Yeah.
All right. So I appreciate the kind introduction. And I think, as most of us do, we wear a lot of various hats in our professional lives. And one of the hats that I've worn for some time now has been focusing on care quality for PCI in particular, so percutaneous coronary intervention, so patients with coronary disease who receive stents. And obviously they're a ripe population for cardiac rehab and certainly receiving the benefits of attending cardiac rehab. That's kind of how I got into this work and have since created a lot of connections with various individuals involved with cardiac rehab throughout the state of Michigan. Obviously, our colleagues here at Michigan Value Collaborative and the Michigan Cardiac Rehab Consortium, which we kind of co-founded together in trying to really understand why this therapy, which has no side effects, is cost-effective and beneficial, is so dramatically underutilized. And particularly when there's great evidence that it reduces hard outcomes like cardiovascular death and readmission, but also really patient-centered outcomes like quality of life. It improves quality of life. So I'm going to focus very specifically on this idea of a liaison-mediated cardiac rehab referral and kind of how this idea came to be and some of our more recent observational data demonstrating their benefits. As Christy noted, please feel free to jump in the chat, or I certainly do not mind fielding questions on the fly as well. And Christy, feel free to keep me on track if I veer off track with questions or am going off script. So this work that I'll be presenting today, obviously none of this can be done by a single individual. So I want to make note of our co-authors um, uh, on this work around liaison-mediated referral. Lexi Mansour is the first author on the manuscript, which is under review currently, and she was a fantastic medical student here at the University of Michigan. Is now a medicine resident at Johns Hopkins in Baltimore. And then everyone else here, hopefully a lot of familiar names throughout the state in relative to cardiac rehab. So what we know, and I won't dig in too deeply into this because I think this audience understands the benefits of cardiac rehab, but we know it's beneficial and we know it's cost effective. We know it's dramatically underutilized across all the indications for cardiac rehab, whether it be coronary disease that's not revascularized, which is probably the lowest among coronary disease in terms of cardiac rehab participation, then cardiac rehab participation for patients undergoing PCI is somewhere around 20 to 30% nationally. It's a little bit better in the state of Michigan, as is the case for pretty much all of Michigan is actually better than the rest of the nation in terms of cardiac rehab, as well as a lot of other quality outcomes. And it's probably the best amongst patients with coronary disease who undergo surgical revascularization. Closer to 50% of patients attend cardiac rehab within 90 days. Nevertheless, it's dramatically underutilized. And we know, not surprisingly, that there are patient, hospital, and provider factors that are associated with cardiac rehab participation. We here in Michigan have published on this in these two articles demonstrated here, demonstrating various patient-level demographic characteristics that are associated with attending cardiac rehab. You can see kind of in the middle on my cursor, whether the patient presents with a large heart attack, what we call a STEMI or ST elevation myocardial infarction, is one of the greatest factors in increasing the odds of attending cardiac rehab. And then there are various socioeconomic factors kind of down here in table B that are adversely associated with attending cardiac rehab. More recently, we looked at kind of what's the effect of the hospital and the provider in attending cardiac rehab. So these are among people who received a referral for cardiac rehab. What are the odds of attending cardiac rehab if you kind of randomly selected two separate operators or two separate hospitals within our state of Michigan? And generally speaking, there is a dramatic hospital effect and an attenuated but still significant provider effect. So the operator who performed the PCI has an effect on whether an individual goes to cardiac rehab or not, regardless of whether they received a referral, since these were all patients who received an in-hospital cardiac rehab referral. And so as we know, again, not surprisingly, a cardiac rehab referral is necessary but insufficient to getting someone to cardiac rehab once they've left the hospital or the immediate episode of care. And so the method by which a referral occurs matters. This was from a paper published over a decade ago now by Sherry Grace, demonstrating that various forms of referral have various levels of effect on downstream participation. So an automated referral, though it sounds great and certainly increases the rate of referrals being placed, doesn't necessarily in and of itself translate to a patient going to cardiac rehab. We know that facilitated referrals have rates between 30 and 50%. A systematic automatic referral plus liaison facilitation really increases that. And then if you go systematic plus liaison facilitated plus a motivational letter, so kind of some follow-up in the post-discharge setting, it probably has the greatest effect. And we've talked about this really when the Cardiac Rehab Consortium was first thought of back in October of 2019. Dr. Katayan gave a great talk about what their site was doing at Henry Ford in terms of trying to facilitate patients from the inpatient setting to the outpatient setting. And not all sites have the ability back then nor now to have a dedicated FTE or a cardiac rehab personnel perform a liaison role. So we tried to think of what were some of the components of a liaison that we could translate into hospitals, either using a cardiac rehab personnel or their current setup to facilitate referral, to translating that referral into downstream participation. So we started collecting a data variable in our registry to really track from a quality purpose, whether not only whether referrals were being placed, we've tracked that for over a decade, but whether there was a face-to-face discussion with the patient regarding cardiac rehab participation. We didn't necessarily mandate what they said, but we mandated that it was documented that a face-to-face discussion was had, that the patient received a cardiac rehab referral, and ideally these were the benefits, and this was the necessary next step in their care. And more recently, we've evaluated whether cardiac rehab liaison referral, what we call a liaison-mediated referral strategy, was associated with downstream improvements in cardiac rehab participation. And specifically within our registry, which we've linked to claims data from MVC, we could track not only was our in-hospital referral placed, but we could see if that data variable of a liaison-mediated referral being performed at a hospital or not. And then we could track whether they attended at least one cardiac rehab session within 90 days of hospital discharge. And these were for PCIs performed between January of 2021 through April of 2022. So about 9,000 patients who underwent PCI and were referred to cardiac rehab upon discharge, and about half underwent a liaison-mediated referral process, and the other half did not. We also wanted to really understand what a liaison-mediated referral really was within the registry. As I said earlier, we didn't really provide very strict definitions of what a liaison's role should be, but rather the function of a liaison doesn't have to be a single individual. It could be multiple individuals, but functioning in that purpose was to have a face-to-face discussion with the patient after their PCI about cardiac rehab. And so we had sent a 2-question survey to sites who had greater than a 40% liaison implementation rate to really understand what their roles were, and who performed those roles. Really, those were the 2 questions. You can see here, there's technically 3 questions. The first one I don't really count since it was the site they were representing. But the second question listed here was, what of all these things, including a free text response, was the liaison at their site kind of responsible for? And what other clinical roles did those staff members occupy? And for the most part, the vast majority of sites, it wasn't a cardiac rehab staff person necessarily, but advanced practice providers, discharging physicians, residents or fellows, if the site had them, who were discharging the patient the following day, but having and documenting that a face-to-face discussion occurred. So let's jump into the data. As I said, about half didn't have a liaison-mediated referral, about half did. I'm not going to go through every line of this, but I'll pick out, I think, 2 salient patient characteristics that differed between those who received a liaison-mediated referral and those that didn't. One was coronary disease presentation. As I alluded to earlier, we know that patients who have a more severe form of a coronary presentation, like a heart attack, were more likely to attend cardiac rehab. Interestingly enough, patients who had a more severe form, STEMI or non-ST elevation acute coronary syndrome, both of these being urgent or emergent inpatient diagnoses and PCIs, were more likely to receive a liaison-mediated referral than not. And more specifically, when categorized by their whether they had a less emergent non-ACS, most of these patients are outpatient PCIs, so they may stay overnight in the outpatient kind of PACU area and go home the next day, or some are same day discharges, were less likely to receive a liaison-mediated referral. And then secondarily, patients with a history of heart failure were less likely, had a lower rate of receiving a liaison-mediated referral compared with no liaison. And that, I think, is an important point. We know that heart failure in general, as the primary indication of cardiac rehab, is the diagnosis associated with the lowest rate of cardiac rehab participation, not only in Michigan, but nationally. And I think some of it has to do with the waiting period that a person has to be stable in their heart failure status without a readmission before attending cardiac rehab. But I think this is a vulnerable population in terms of a handful of different barriers to participating in cardiac rehab. Yet there's an opportunity here in terms of trying to really focus on this population for liaison-mediated referrals. And this is the kind of rate across the sites in Michigan who underwent PCI between January 2021 through April of 2022. And you can see a very wide variation among the sites. The average is just under 50% in terms of liaison-mediated referrals, but some are very high performers, and one is providing a liaison-mediated referral every time, and some are far on the left. And kind of similarly demonstrated here for the study standpoint, we limited it to sites with 150 or more cases. Excuse me, so we kind of took away the low volume sites so as not to skew the distribution. And I've also noted here in red that in a sensitivity analysis of our data, we removed really high performing and really low performing sites so as not to have their effects, given that some of these sites are very high volume sites, really skew our overall findings. So we performed some sensitivity analyses to ensure that our findings were robust to exclusion of these sites. And to the punchline. So our primary finding here, which is the liaison effect and odds ratio, demonstrate that there was a 21% higher likelihood of attending cardiac rehab within 90 days of discharge after a PCI when a liaison-mediated referral was used compared with non-liaison-mediated referrals. This is pretty substantial. I mean, if we're thinking about ways, some of which are quite challenging, potentially incentivizing hospitals and providers monetarily to get patients to cardiac rehab, paying for transportation and alleviating some of these barriers, this may be a relatively low cost, not necessarily low touch, because you are having face-to-face discussions, but low hanging fruit in terms of implementation to try to improve the attendance of cardiac rehab. And I'm not going to go through the rest of these other than to say that it was robust to the sensitivity analyses that we had described earlier. We excluded high and low performing sites. This is number 2 here. We also allowed the site level variation to change. This, from a statistical standpoint, is a random slope model in a hierarchical model. And then we can also see here, as we had demonstrated previously, that there is a hospital level effect independent of all these other factors. So we were controlling for a number of different patient level characteristics, and these were the independent effects of a liaison-mediated referral. We also looked for significant kind of subgroup interactions. And although none of these reached the level of statistical significance, sometimes because of the number of patients, as you can see here on the right, I think the most interesting one was the numerically higher odds of cardiac rehab participation for dual eligible beneficiaries compared with non-dual eligible beneficiaries when looking at the liaison subgroup. So we know that dual eligibility, which is having Medicare and Medicaid, Medicaid in this example being associated with some socioeconomic factor for the family and patient. Generally speaking, dual eligibility, if I showed you that first slide, if I went back to that first slide, was associated with a lower likelihood of attending cardiac rehab. Yet this was a potential way where liaison maybe had a disproportionate effect, again, not reaching statistical significance, but a disproportionate effect in improving cardiac rehab participation among dual eligible patients. So I think another interesting finding. Obviously it requires further investigation and study, but really could try to bridge some disparities that we certainly see within cardiac rehab. And then looking at kind of a time to event or time to first cardiac rehab analysis. This is a Kaplan-Meier plot, but when we control for the same factors, but have the outcome being time to the first cardiac rehab visit, you can see that the line in red, which are those who received a liaison-mediated referral, compared with the line in blue, those without, those who received a liaison-mediated referral were much more likely to attend cardiac rehab sooner than those who did not receive it. You can see the curve splitting right around the 2-week mark, and a significant adjusted hazard ratio in this Cox model associated with a liaison-mediated referral. There was a 10.7% percentage point higher unadjusted 90-day cardiac rehab participation rate. But maybe more importantly here, the median days to first cardiac rehab session was reduced by 5 for the liaison cohort compared to the non-liaison cohort, and adjusting for other factors, this was statistically significant. So looking at that supplemental analysis, really trying to understand what was a liaison-mediated referral within our consortium. We see here that really these were the things that a liaison performed among high-performing liaison sites with a greater than 40% rate of a liaison-mediated referral. They were initiating discussion of the benefits of cardiac rehab with patients and families prior to discharge. About 75% were assisting patients in identifying an appropriate cardiac rehab location, I can speak personally for Michigan Medicine since I know our site, we're often thinking about this, and I know our cardiac rehabs are doing geographic referrals closer to patients' homes. In some sites, they're scheduling the initial outpatient cardiac rehab eval appointment, and then less so the remainder of these things. I think a lot of this has to do with bandwidth and whether there's dedicated FTEs or not, or if this individual is performing multiple different roles or functions within the Cardiovascular Institute or in the cath lab. And then the clinical roles here, you can see that at a number of sites, it is the cardiac rehab staff person, but about 50% of the time it's a registered nurse or the advanced practice provider, or in a minority, it's a discharging physician. And in some cases, it's other. This was usually the discharging fellow or resident on the team. So some lessons learned here. I think liaison-mediated referrals are associated with a higher odds of cardiac rehab participation within 90 days. This was significant, accounting for multiple different factors, including variation across hospitals. Liaison duties frequently included patient education and assisting with barriers to participation. I think the education part cannot be stressed. So often an automated referral is placed. Our rate of referral in the state of Michigan is very, very high among sites performing PCI. We moved that bar over the last decade, yet our rate of participation is about 33% overall. Some sites up to 60%, some sites as low as less than 10%. Yet, finding factors that may be relatively low, not resource intensive, could substantially improve the rate of participation downstream. I think implementation doesn't necessarily require a dedicated FTE. The liaison duties are frequently incorporated into existing workflows at our institution in the cath lab. Our discharging APPs who see the patient with the operator who performed the PCI the following day are having that conversation with the patient. Often the discharging physician, such as myself, will have that conversation with the patient. And there remains significant hospital level variation in participation and provides an opportunity for further evaluation. I'm personally really intrigued by and interested in whether these sorts of strategies can really reduce, not only increase participation across the board, but really try to reduce some of the disparities that we see in cardiac rehab participation. So in conclusion, liaison-mediated referrals are associated with higher odds of cardiac rehab participation within 90 days of discharge. The liaison role includes education, assisting with barriers, and there remains significant variation across hospitals that I think provide an opportunity for us to really level the playing field and move everyone up towards the million hearts goal of 70% participation. So what do we do next? I think since a lot of this data and data analysis had occurred, we've created the Michigan Cardiac Rehab Network. We obviously have pay for performance and value-based payment things within MVC as well as within BMC2. I think cardiac rehab has been a really important goal for these two consortia. I think the Michigan Cardiac Surgery Consortium is also looking very closely into this. So there's a lot of effort and engagement and interest in this area. And we partnered with HBO, who've been fantastic, and really run with this idea of how we can try to emphasize healthy behaviors to our patients so they can redeem all the benefits of cardiac rehab. And so I encourage everyone, if you haven't already, and if you were at the in-person meeting that we had late in the fall, the HBOM group and the MyCR group put on a fantastic PowerPoint demonstration of the website, michigancr.org. It is beautiful. It is very informative. And there are a lot of great resources on there, and a lot of tremendous work from so many people, many of whom are on the call, went into this. So I encourage everyone to go into it. If you click on providers at the top, they have a specific section around cardiac rehab liaison. Again, this is not a specific FTE. It is nothing more than further information and potentially what I think is a really cool customizable postcard. If you click that orange button at the bottom, you will get these two slides essentially in a PowerPoint format, and your facility can modify them how you wish, however you wish, print them out, sign them, hand them to patients. You can obviously change the photo, since that's probably not anyone on the phone call or on this call here. But add your name, you can put a bio down, you can have a physician sign it. There are physician cards as well, I believe, that come in bifold that you can sign up for and get mailed to you. But I think it's a great way where so often patients are sent home with a packet of information, usually 8.5 by 11 printed sheets of paper that somewhere within there is you should go to cardiac rehab, and it's usually mixed in between the medicines they came in with and the medicines they're leaving with, which is a super confusing thing that we do to patients. Yet we buried a really important component of their care in there. And so having something different, something that stands out, something that I know in our PCI world, we give patients stent cards. They usually keep those in their wallet or purse, or on themselves or somewhere safe in their home. This is, again, kind of something similar that can really stand out to them as they're walking away. And it is truly the next step in their care. It is so critically important and provides a point of contact for the patient with the healthcare system that's not as daunting, and usually a really good social environment as well as they're in recovery. So that's it. Thank you. I know I went pretty fast. I obviously ended quite early, but hopefully this leaves time for discussion, and happy to answer any questions from here. Thank you for the opportunity.
Thank you so much. What questions do we have for Devraj today? Thank you for that great presentation.
Of course, my pleasure.
Hi, Devraj. This is Erin Kaplan from MVC. I just have a quick question. If you could speak to, for sites who don't have this role already within their institution or organization, do you have any tips or tricks for how folks could, kind of get started with the conversation with leadership or make the business case?
Yeah, it's a great question. I think there are two parts to it, and one is not really answering your question. I'll start with that one, and then I'll answer your question. One is, I obviously think I mean, this by definition is multidisciplinary, right? And so you not only need to understand where your patients are, quote unquote, coming from in terms of within the healthcare system. In my world, it's the cath lab, but as I think about cardiac rehab more broadly, it's our inpatient settings, it's our outpatient cardiovascular clinics who are seeing patients who may be eligible, and it's our cardiac surgeons. And I'm not even, we can obviously extrapolate into structural heart disease and things like that, but those are kind of the general silos, if you will, that exist in most healthcare systems that need to be broken down and have an engagement. And so if you can get more of those folks on your side and form your multidisciplinary team and thinking about the importance of this, I think that's the first step in trying to improve cardiac rehab participation, but also thinking about the role of a liaison. I think the second part is, and maybe the incremental part, it's obviously incredibly important to engage with leadership throughout the healthcare system, particularly because inpatient and outpatient and most sites are very distinct silos. And that's if you're still within the same healthcare system. Some hospitals on here and clinics on here are disassociated with the cardiac rehabs, and so they're not necessarily that affiliation. So those can be communication challenges as well. But in order to have that discussion with kind of higher level administration, I think the data that MVC provides around cardiac rehab is a great starting point. And the data that's posted on Michigan CR, and you could, obviously on the Million Hearts website and CDC website, are incredibly important in terms of just looking at patient outcomes and quality. The financial part is always the biggest challenge. I think most folks on here who work at cardiac rehab sites would agree that they are understaffed and under-resourced somewhat perpetually. COVID obviously did not help that at the time. I think they're often fighting for more resources just to perform their function in cardiac rehab, let alone an FTE for a liaison on the inpatient setting or even the outpatient cath lab. Therefore, I think, and the reason I actually feel pretty strongly about the liaison-mediated referral process is that it doesn't necessarily require that you ask for an FTE. But if there are ways, there's obviously different levels of engagement of a liaison or their roles and responsibilities. You know, to have the liaison call the insurance company, make sure they're prior auth, call the cardiac rehab, get their first appointment scheduled is very different than simply having a conversation around education and the benefits of this. And here, you know, this is what you'll expect, the phone call in this time frame and a first cardiac rehab appointment within this time frame. Those are all very different levels of engagement and time intensiveness. So that's why I feel pretty strongly that the FT itself should not be the barrier in starting this process, but rather working within existing workflows at institutions to try to get the benefit translated. Because, you know, at the end of the day, if we can move that number north in terms of cardiac rehab participation, I think more sites are going to meet their goals in terms of MVC goals and BMC2 goals, which is great. But most importantly, patients are going to get the benefits of cardiac rehab. And if you can demonstrate your cardiac rehab system is full, and you know, we can argue about Medicare reimbursement, and that's probably a very valid argument. But if we're getting cardiac rehabs full, then I think there's an economic benefit for the healthcare system.
Thank you so much.
Yeah. I will, there's some here.
Yeah, there's 2 questions in the chat. I can read them off if that
Sure,
would be
please.
helpful.
Yeah.
So one from Taylor, has there been any discussions or ideas regarding placing the MyCR handouts in cardiology offices or discharge clinics?
Yeah, it's a great idea. You know, we haven't really prescribed how and where sites should use this data. And frankly, you know, HBOM did a great job creating them, but then also said, download them, modify them, do whatever you think is best for your institution so that it's going to be most effective for your patients, which is fantastic. I think that's a great place to have them. You know, the one thing I would caution against, just given the general data out there on automation, you know, I think handouts are great. Automating referrals are fantastic because for a long time, 15 years ago, patients weren't even being referred to cardiac rehab. But they themselves often, you know, automating referral can sometimes take away the opportunity to have a discussion about the referral. And that's where I think, you know, just having a handout and putting it in the discharge paperwork is probably insufficient. But rather having a handout, having a conversation, giving that handout with that information to reinforce that conversation is probably the right way to do it. Now, I think a great idea, which is often missed, and I'll speak it for the cath world, is that we have this conversation after the event. For so many patients, we could have the conversation before the event, and probably should have the conversation before the event. Take a page out of our surgery, out of our surgeon's playbook, who sit in the office and say, your bypass surgery is on this date. You'll be in the hospital for about 5 days. I will see you at the 30-day visit. And right after that, you're going to cardiac rehab. Those are the things that are going to happen to you. And very often we put a stent in, we say, here's your aspirin and Plavix, and oh, by the way, you should go to cardiac rehab. And rather than putting that up front and putting it as a part of their expectation.
Great, thank you.
Yeah.
The next question from Gregory, do we see a reduction in participation for patients that have referrals sent to cardiac rehab programs that are not within the health system that performed the procedure? I think there is a lot of barriers created when referrals leave the health system.
Yeah, it's a great question. And I think anecdotally and intuitively, I completely agree with you. In the data, it's been a little bit hard since we don't have a terribly reliable variable demonstrating one's cardiac rehab's quote unquote affiliation with a health system. And obviously affiliation can be a somewhat heterogeneous term in terms of the strength of said affiliation. I will say that in that Jack paper up at the top in 2019, there was a variable here, and I can scroll back to it. There was a variable here that we measured the distance from the nearest CR facility to the PCI site. So we had cardiac rehab addresses, actual addresses, and we had site actual addresses. And so we could get, rather than looking at zip centroid, which is usually the problem when looking at patient level geography, because you don't have the patient's address, you just have their zip code. So you kind of pick the center and hope it all averages out, which we know is probably not true. We did see that the further away a cardiac rehab site was from the facility where the PCI was performed, potentially as a proxy for an affiliation, right? Most cardiac rehab sites are, if they're affiliated with an institution, are either located on site or located nearby. Not necessarily always the case. The less likely, the lower the odds of attending cardiac rehab. So that I think that is probably the best evidence I've seen in terms of, I'm obviously biased, this was the paper I wrote, but that I've seen in terms of that that phenomenon that you're describing, which is, I think, when they're exiting the health system, it can be a more challenging barrier. But I think we see that across healthcare in general, right? You know, when we take care of a patient, when I take care of their cardiac issue, but they're getting their rheumatologic care at a different institution, it's just hard to have that conversation. And I think cardiac rehab, sadly, is no different. Great questions. Well, I forgot to put my email down here, but I'll just throw it in the chat. You're always welcome to send me an email if you have any questions or comments or thoughts or ideas, initiatives, you know, whatever it may be as it relates to cardiac rehab. I think it's always really fun and exciting to hear about different sites and institutions, experiences, and solutions, frankly, as we can all probably learn from one another.
Wonderful. Thank you so much. I do have one last question for you. I was curious, in that survey that you showed, you know, that you had sent to the sites who have this referral strategy in place, there's a lot of different clinical roles that are, you know, there. Have you found that there's any difference in participation based on the clinical role of the person doing that liaison?
Yeah, fantastic question. We have not looked at that, nor have the data to specifically answer that question. But I think it's a really important one. You know, I kind of view this as, I can tell you that probably having a conversation with the patient is impacting them in terms of getting the cardiac rehab. I probably cannot tell you exactly how you should have that conversation or who should have that conversation. But I think at a minimum, in some ways, I kind of view that to be enlightening in that, and maybe even relieving in that it doesn't have to be super prescribed, but it just has to be dedicated and specific to cardiac rehab and in person, face to face, which is a relatively low bar to achieve. But there's probably, like I said before, there's probably incremental benefit to the intensity of that conversation or that role. But it is a great question, probably something that we could design a study around to better really specify that benefit.
Wonderful. Thank you. Does anyone have any other last questions for Devraj before we close out today? Okay, wonderful.
Thank you again for the opportunity.
Yeah, absolutely. Thank you so much for presenting. I am going to go ahead and pull up my screen and share some last minute remarks. So I did just want to highlight the remaining work groups in the Cardiac Rehab Workgroup series. As a reminder, if you would like to receive the 0.25 engagement points for your attendance on this workgroup series, you need to attend all 4 in the series. So the next Cardiac Rehab Workgroup we have is on May 30th, followed by August 22nd and November 21st. You can register on our events page on our website or in the link that you'll see here in the PowerPoint slide that will be shared with you following the meeting. And for some upcoming work groups, we do have a post-discharge follow-up work group on March 12th that is going to feature Lisa Powell of Sparrow Hospital, And then following later in March, on March 28th, we have a rural health work group, which is going to feature Laura Misbalon and Jeff Nagy from the Michigan Center for Rural Health. As a reminder, all work groups do occur virtually from 12 to 1 p.m. So with that, thank you so much, Devraj, for presenting today. Thank you, everyone, for attending. Thank you for your participation. As a reminder, Erin did post the link to the survey for completion to receive that attendance in the chat, and we will be posting it in an email following the work group as well. As a reminder, please only complete that survey once, and please make sure that you select the hospital that you'd like to receive the attendance credit for, so that we can appropriately manage that. Wonderful. Thank you again, and I hope everyone has a great rest of your day. Thanks so much.